Welcome all to this evening of ISBT master class. So today our faculty is Professor Uttam Kumar Nath. He was initially in our medical college Calcutta. I was a student under him. So it's my privilege to introduce him as a speaker of today's class. So his topic is very interesting topic with multiple facets. So, and it is a benign hematology topic so it's more important regarding consultative hematology and pure benign hematology. So his topic is management of immune hemolytic anemia. So over to Uttam sir for his talk.
Thank you, Dr. Devmallo, for the kind introduction. I hope I am audible.
Yes, audible and visible in your slides. Decks are also visible.
So today's topic is management of immune hemolytic anemia, which I believe is a very vast topic. And so I have taken the privilege of focusing mainly on the autoimmune hemolytic anemia, which is the most common autoimmune hemolytic anemia, the different types, which are the commonest hemolytic anemias other than thalassemias, which we see in our day-to-day practice. So the learning objectives for today's class are how we can classify autoimmune hemolytic anemia or AIHA, then the differential diagnosis of AIHA, which is very important, management of warm antibody AIHA in adults and children. Warm antibody AIHA constitutes almost 75 to 80% of all AIHA, and the management in adults and children are almost similar with very minor differences. Then the management of cold agglutinin disease, which is cold antibody mediated AIHA, which constitutes another almost 15% of AIHA. Brief discussion on paroxysmal cold hemoglobinuria, which again is mediated by cold reactive autoantibodies, and a very brief discussion on secondary AIHA, that is autoimmune hemolytic anemia, which is associated with different drugs, infections, autoimmune disorders, malignancies, etc. So brief classification of autoimmune hemolytic anemia. As you can see, warm reactive or warm antibody AIHA is the commonest, almost 75 to 80%, which can be primary, or previously it was called idiopathic, and secondary to all these different conditions. Second subtype is cold agglutinin disease or cold antibody AIHA. Again, it can be primary or it can be secondary to different infections, viral infections, mycoplasma, SLE, rheumatoid arthritis, malignancies, most commonly non-Hodgkin lymphomas, and then the PCH or paroxysmal cold hemoglobinuria, which again is most commonly post-viral, but sometimes it can be idiopathic also. So with this classification in the background, we'll discuss briefly the differential, the common, I have focused on the common differential diagnosis of AIHA, thrombotic microangiopathies, which are associated with microangiopathic hemolytic anemia, like conditions like TTP, like hemolytic uremic syndrome, etc. Then PNH. PNH is an important DD of AIHA. Macroangiopathic hemolysis, like dysfunctional prosthetic valves, heart valves, and other causes of trauma. Now, some congenital hemolytic anemias can mimic AIHA, particularly in children, like RBC membrane defects, hereditary spherocytosis, elliptocytosis. Then the RBC enzymopathies, it can either mimic some acute hemolytic episode of AIHA, as in G6PD deficiency, or it can be chronic, like pyruvate kinase deficiency. Drug-induced hemolysis, as I said, G6PD deficiency. Mind it, this is not same as drug-induced AIHA, where the drug itself is responsible for secondary AIHA. This is mainly in G6PD deficient patients, where some drugs, oxidant stress or drugs, can cause drug-induced hemolysis. Delayed hemolytic transfusion reactions to minor RBC antigens can present with a similar picture. And we must not forget malaria, which is an important cause of hemolytic anemia due to infection in the tropical countries. Now, a brief overview of AIHA, as I've said, warm antibody AIHA, cold agglutinin disease, and PCH. The autoantibodies vary, either IgG in these two conditions or IgM in cold agglutinin disease. The thermal reactivity, that means the temperature at which the antibodies bind to the RBCs vary. Like in warm AIHA, it's usually at body temperature. In cold agglutinin disease and PCH, the antibodies are more avidly binding to RBCs at relatively lower temperatures. Now, ability to fix complements and cause complement-mediated hemolysis are seen more in CAD, cold agglutinin disease, and PCH. Coombs test typically is positive for IgG as well as C3D in warm AIHA, but in CAD, cold agglutinin disease, usually it's positive for the C3D of part of the Coombs reagent. Okay, the target antigens, all these things, site of hemolysis, major site of hemolysis, these things vary. Like in warm AIHA, mainly the spleen is the site of extravascular hemolysis, whereas in cold agglutinin disease, extravascular hemolysis occurs in the reticuloendothelial cells of the liver. Also, intravascular hemolysis, sometimes severe, can occur in both cold agglutinin disease and PCH. Treatment I will be coming to later. This is a normal blood picture. You can see the normal central pallor and size of the RBCs. And this is the picture in AIHA where you get reticulocytosis leading to presence of polychromatophilic macrocytes on the peripheral smear, some spherocytes and some microspherocytes. These are the spherocytes and these are the microspherocytes which result from membrane loss and phagocytosis in the spleen. And this is the typical picture of cold antibody hemolytic anemia or cold agglutinin disease, where you get irregular clumps of RBC due to RBC autoagglutination. Now, I will not go into the details of diagnosis because I think it has been covered in the previous class. Direct Coombs test or direct antiglobulin test is the mainstay of diagnosis of autoimmune hemolytic anemia of all types, warm, cold. Okay, so that is usually positive in almost 95% cases of AIHA, and the rest of 5% cases, usually the DAT is negative because of the presence of some non-IgG antibodies or because of antibodies which bind with low affinity or with in lower numbers. All these things are causes of negative DAT. Okay, so that is the mainstay of diagnosis of AIHA along with a CBC, RBC parameters, reticulocyte count. All the others like haptoglobin, LDH, all these are supportive investigations only. Now, what are the patterns of DAT in AIHA? As I have said, in warm AIHA, usually anti-IgG and or anti-C3D. And in cold antibody, AIHA and PCH is mainly anti-C3D part. And in drug-induced, it's almost same as warm AIHA. And the antigens vary. Like in PCH, it's the P antigen of RBC. In cold agglutinin disease, it's the capital I or small I antigen on RBCs. And in the warm AIHA, mainly the RH complex antigens. Actually, any antigen can be a target, but most common are the RH complex antigens like capital D, C, E. Okay. And these warm AIHA antibodies are typically pan-agglutinins. That is, they bind avidly to commonly present antigens on the RBC surface. That is why they pose problems with transfusion, which I will come to later. Now, this is a basic algorithm of any suspected AIHA or suspected hemolytic anemia, as I have already discussed, patient can have hemodynamic instability, severe, mild to severe pallor. Sometimes, if there is massive intravascular hemolysis, there can be acute kidney injury, DIC, and life-threatening hypoxemia causing cardiac or cerebral anoxia. Okay, so an urgent workup and treatment are indicated. So we have to see whether the patient has relatively recently received any blood transfusion or not. If within 4 weeks of the episode any transfusion history is there, then we have to consider some transfusion mediated alloantibodies or some delayed hemolytic transfusion reactions. However, if there is no recent transfusion history, then we can consider AIHA, drug-induced infections, hemolysis, infections, and other rare conditions. And again, as I have said, a positive DAT helps us in diagnosing the hemolytic anemia as autoimmune hemolytic anemia. Okay. Now, these are a few clues which we can get from the history examination and the blood peripheral blood smear examination, like cystocytes, spherocytes, microspherocytes, different conditions, malarial parasites. Then from the history, as I have said, that we can consider the different differential diagnosis of AIHA. Coming to the most common subtype of AIHA, which is the warm antibody AIHA. It is, as I have said, due to active antibodies which are active at normal body temperature, which is typically around 37 degrees. Typically, these are IgG antibodies, and in contrast with cold agglutinin disease or PCH, where contrast with cold agglutinin disease, where there are IgM antibodies. Primary or warm AIHA, it accounts for roughly half of the warm AIHA which we see in our practice, and the other almost 50%, in some series 50 to 60% are secondary to some underlying condition, which we'll discuss. Now again, this is a brief algorithm of how to approach a suspected warm AIHA patient. We have to see how severe the anemia is. If the anemia is severe and there are symptoms like hemodynamic compromise, severe breathlessness, symptoms of cerebral or cardiac ischemia, then we have to manage the patient on emergency basis, which consists of urgent red blood cell transfusion. In AIHA, any AIHA patient, RBC transfusion must always be done in consultation with the transfusion medicine specialist, because it is very difficult to get compatible, so-called compatible blood unit, and often we have to go with the least incompatible blood unit available in the blood bank for life-saving RBC transfusion. Okay, the dictum in AIHA patient is, if the patient is in need of RBC transfusion, we must never withhold transfusion for the fear of complications. On the other hand, if the patient is relatively stable, then transfusion may be deferred and the definitive treatment should be started. I'll be coming to the definitive management of warm AIHA later. Okay. What are the first line treatment options in primary warm AIHA? First line treatment options most commonly used is corticosteroids. In outpatients, we use corticosteroid, prednisolone, oral prednisolone. In hospitalized patients, sometimes we use methylprednisolone in equivalent dose of prednisolone. However, as per up to date and as per several evidence in the literature, rituximab plus prednisolone combination may be relatively better option for AIHA, warm AIHA, particularly in hospitalized patients. I will come to the evidence later. What are the adjunctive therapies? IVIG, although it's not as effective as in ITP, immune thrombocytopenia, it is an important adjunctive treatment. In patients with severe AIHA, we can go for IVIG. In patients with life-threatening hemolysis due to AIHA, warm or cold, we can go for IVIG. However, higher doses of IVIG are required. Plasma exchange. Warm AIHA is a category 3 indication, disease condition as per American Society of Apheresis. That means optimum role of plasma exchange is not established in this condition. Now, supportive treatment, as I have mentioned, RBC transfusions are life-saving. Then we must give some folic acid supplementation, 1 milligram per kg, 1 milligram once daily during the acute hemolytic episode. And VTA prophylaxis is important in hospitalized patients because AIHA is associated with increased risk of deep vein thrombosis. RBC transfusions, as I have said, if anemia is severe and there is hemodynamic compromise or organ dysfunction, then it should be transfused as an emergency. Okay, and blood bank or transfusion medicine department is very important for optimum transfusion of safe transfusion of these patients. As I have said, these are pan-agglutinins, so they are virtually present in, these antigens are virtually present in majority of the RBCs. So getting a compatible, so-called compatible blood unit may be difficult. However, fortunately, these patients, AIHA patients, usually tolerate transfusion of relatively incompatible blood units without major hemolytic reactions, because survival of these transfused RBCs are almost same as that of the patient's own RBCs. So they are important to tide over the initial crisis, and usually they can be transfused safely with stringent monitoring. As I said, we must never withhold or deny a transfusion, life-saving transfusion, because of the fear of this incompatibility. How to identify compatible blood for transfusion? One is cross-matching a large number of units, which is most commonly done in our hospitals to get the least incompatible blood unit. Secondly, autoadsorption to remove autoantibodies from the patient's plasma may be used for safe cross-match of donor RBCs. This is the best method actually, but sometimes the time may be too short because of life-threatening hemolysis. So this is a time-consuming process, and the first option is more commonly adopted in our hospitals. Finally, extended phenotyping of the patient's RBCs, which although not available in most hospital blood banks, is the best, another good method of safe transfusion. Coming to the glucocorticoid therapy, choice of steroid is usually prednisolone, 1 to 2 milligram per kg per day. Higher doses are used in children, like 2 milligram per kg in 2 to 3 divided doses. In adults, 1 to 1.5 milligram per kg per day may be used. If parenteral steroid is preferred, equivalent dose of methylprednisolone may be used. Sometimes in severely ill patients because of massive hemolysis, higher doses of methylprednisolone are also used. Like in children, the dose may be 15 to 30 milligram per kg of intravenous methylprednisolone. Now, how long to give steroid in this dose? It is at least 3 weeks. Okay, without giving for at least 3 weeks, we cannot say whether the disease AIHA is primarily steroid unresponsive. The response rates to first-line glucocorticoid therapy is around 70 to 90% as per literature. However, response may be short-lasting, and majority of adult patients, like 50 or more % patients, will invariably relapse within the first year, before 1 year of starting therapy. And definition of steroid unresponsive AIC, as I have said, it is no response after 3 weeks of first line therapy. When to start tapering of steroids? This is important. If there is a response to initial steroid therapy, the response definition is increase of hemoglobin to 10 or more gram per deciliter with treatment. If within 3 weeks there is a response to steroids, then the steroid dose should be tapered very slowly. So as per different textbooks and literature, it's over 2 to 3 months, and sometimes a small dose of maintenance steroid is continued. So how to taper steroids? So it should be tapered by around 10 milligram per week from the starting dose, like 60 or 70, until you reach 20 milligram per day dose. Thereafter, we should not hurry. We should reduce by 2.5 to 5 milligram per week. So it is preferable to reduce by 5 milligram every alternate weeks. Okay, and some patients will eventually need a small dose of maintenance steroids to sustain the response. If, however, there is primary steroid refractoriness, like no response after 3 weeks, we should start second line therapy and taper off the steroid dose rapidly, relatively rapidly, by 10 milligram per week. As I have said, the relapse rate after response to first line steroids is high in AIC, and relapse is an indication for starting second line therapy, plus prednisolone dose may be increased from the maintenance or baseline dose, current dose. Now, regarding the evidence in favor of rituximab plus prednisolone combination versus prednisolone monotherapy, this was a big study from Denmark, relatively large number of patients, 64 patients, considering its AIC. So it was a randomized study, rituximab weekly into 4 weeks, and prednisolone 1.5 milligram per kg per day for 2 weeks, followed by slow taper. The response rates at 1 year was 75% with the combination compared to 36%, and it was significant. Also, the relapse-free survival was better with this combination, and sustained response rates after almost 3 years was also higher compared to prednisolone monotherapy. So this study by Burgens et al. Concluded that rituximab plus prednisolone compared to prednisolone monotherapy may be a better first-line treatment in terms of higher rates and prolonged duration of response in warm AIH. Okay. Another study of 32 patients. Here also the difference in favor of the rituximab plus prednisolone combination was significantly higher compared to steroid monotherapy. Interestingly, the combination was not associated with increased adverse effects. As we know, the rituximab dose used in autoimmune conditions like ITP or AIC is just 4 weeks of rituximab. So it is very safe. Another study which was non-randomized in adult warm antibody AIC showed that even low dose of rituximab, 100 milligram flat dose weekly into 4 weeks, along with a short course of oral prednisolone, was associated with high response rates and sustained response. However, the number of patients in this study was not very high. So considering the latest relatively recent evidence, we may consider upfront rituximab plus prednisolone therapy particularly in hospitalized patients, sick patients of AIH. Here I would like to add that although this low dose rituximab works well in warm antibody AIH, its efficacy in cold AIH, cold agglutinin disease, is not so good. It is not associated with such higher responses, and treatment failures with low dose rituximab in cold agglutinin disease is much higher. So low dose rituximab may be tried only in warm AIH. Role of IVIG, as I have said, higher doses are required, relatively limited efficacy if used as monotherapy, unlike ITP. The doses of 0.5 to 1 gram per kg per day for up to 4 to 5 days is required, and that too the efficacy is only 30 to 40%. However, it may be a life-saving temporizing measure which allows the steroids or rituximab to work. Okay, so it may be tried in patients with severe hemolysis. Now coming to persistent disease or relapsed refractory warm AIHA, we need second line therapies. Again, more than half of patients will require treatment other than steroids and rituximab. What are the indications of second line therapy? Hemoglobin less than 10 gram per day despite therapy, despite treatment, or requirement of prednisolone doses more than 10 milligram per day to maintain a safe hemoglobin level of around 10 gram per dl. Okay, so these are the indications of starting second line therapy. What are the treatment options? If only steroid was used initially, then we can go for rituximab monotherapy or rituximab plus steroid. If rituximab has been administered earlier and disease has relapsed, we can either go for another course of rituximab if it's more than 6 months from first therapy, or we can go for other immunosuppressive drugs like mycophenolate, azathioprine, cyclosporine, cyclophosphamide, warm AIHA. Danazol may be tried, and finally splenectomy. Regarding splenectomy, it is better to defer splenectomy unless we have tried at least 1 or 2 other immunosuppressive agents like rituximab, azathioprine, cyclosporine. Okay. Rituximab, as I have said, has high response rates of around 70% in warm AIHA, and the response may be sustained. It works by suppressing the B cells by various mechanisms. Cyclophosphamide can be life-saving in severe hemolysis due to warm AIHA or even cold AIHA. Okay, in hospitalized patients, intravenous cyclophosphamide pulses may be given, and dose can be 600 to 750 milligram per square meters. Okay, however, long-term use is discouraged because of multiple toxicities. Azathioprine can commonly be used in outpatient setting. Dose is 100 to 150 milligram per day. It can cause myelosuppression, so monitoring of blood counts is important. However, toxicity is less than cyclophosphamide. In warm AIHA, Prabhu et al. From South India has shown good response rates with azathioprine up to 80%. Okay, in patients who were earlier treated with steroids and relapsed. So azathioprine is a good option for outpatients. Same with mycophenolate mofetil. It takes time to work, so it is not suitable for emergencies. However, it can be used in doses of 500 to 1000 milligram 12 hourly on outpatient as an adjunct to steroids sometimes. Same with cyclosporine. We must monitor the renal toxicity of cyclosporine. And the dose is 5 to 10 milligram per kg in 2 divided doses. There are concerns with renal toxicity. However, it is a good adjunct therapy, steroid sparing agent, which allows the reduction of steroid dose, or in patients with long-term steroid toxicity, cyclosporine monotherapy can also be used. Danazol up to 600 to 800 milligram per day can be used. In children and young adults with AIHA secondary to or coexisting with autoimmune lymphoproliferative syndrome, sirolimus works. Regarding splenectomy, we have already discussed the current status of splenectomy. After failure of glucocorticoids, rituximab, and at least 1 or 2 different immunosuppressive second line drugs, response rates are 75 to 90%. It usually doesn't work in cold antibody AIHA, and also it is contraindicated in ALPS. As we know, vaccinations and post-op thromboprophylaxis, patient education regarding risk of sepsis are must for consideration of splenectomy. After warm AIHA, we'll briefly discuss the cold reactive antibody mediated AIHA, which are cold agglutinin disease and less commonly PCH. Okay, what are the differences between CAD and PCH? CAD occurs mainly in older patients, and often there are cold related symptoms like livedo reticularis, acrocyanosis, okay, on exposure to cold. On the in contrast, PCH is now mainly a disease of children, and it occurs after viral infections and viral like illness. Okay, the associated diseases, as I have said, in cold agglutinin disease, invariably there is a monoclonal population of B cells, which may or may not be overt lymphoma. Okay. Other causes of cold agglutinin disease are mycoplasma, infectious mononucleosis, and MGUS, usually IgM MGUS. Other autoimmune disorders like SLE are important causes of cold agglutinin disease. Okay. Clinical findings in cold agglutinin disease, anemia may or may not be there, but other cold-related symptoms are often present, like acrocyanosis, Raynaud's phenomena, fatigue, mild icterus particularly during the winters, dysphagia for cold foods or liquids, and in severe cases, hemoglobinemia and hemoglobinuria may be there. Okay, in PCH, again, there can be hemoglobinemia and hemoglobinuria after cold exposure, along with symptoms like fever, chills, back pain, anemia, and Raynaud's phenomena. The hemolysis in cold agglutinin disease is mainly extravascular, okay, but it can rarely be intravascular if there is massive hemolytic crisis. We have already discussed the DAT findings in these conditions. In PCH, hemolysis is mainly intravascular, okay, and the target antigens different, as I have mentioned. In lymphomas, the antibodies are usually monoclonal in cold agglutinin disease, like NHL. However, in viral infections, mycoplasma, these are usually polyclonal antibodies. Coming to cold agglutinin disease, it can be very mild, it can be subclinical, it can be severe or even life-threatening. Here the antibodies usually bind to the RBCs when they are circulating in the peripheral circulation, like in the cutaneous vessels. When they are exposed to lower ambient temperatures, they bind. Then when they reach the core temperature, they may or may not cause hemolysis. Okay, these antibodies are IgM, so they can cause autoagglutination of RBCs. Okay, and the target, as I have said, are capital I or small I antigens on the RBC surface. Primary cold agglutinin disease is idiopathic, and secondary cold agglutinin disease is also called cold agglutinin syndrome. It can be secondary to autoimmune conditions like SLE, rheumatoid arthritis, secondary to infections like mycoplasma, infectious mononucleosis. It can be secondary to malignancies, most commonly B cell NHL. And it is usually said that invariably there is a clone of low grade or indolent B lymphoproliferative disorder, which may or may not be evident on bone marrow biopsy or flow cytometry. Okay. Now this is an algorithm of cold AIHA. We have to see whether it is clinically significant or not. That means whether it is associated with severe hemolysis or not. Okay. If primary cold agglutinin disease is likely, a complete evaluation is important, and if there is need for rapid treatment, emergency treatment, then transfusions and emergency therapies are started. If treatment is indicated but not urgent, then it can be started on outpatient basis. Treatment of secondary cold agglutinin disease is again directed at the underlying condition. Okay. What is the treatment of cold agglutinin disease? Dr. Depalla, we need another 5 minutes. Okay. Cold agglutinin disease, most important treatment management is to avoid cold, including cold IV fluids, exposure to cold with RBC transfusion must be administered through an inline warmer to avoid this cold-induced hemolysis. Plasmapheresis or IVIG can be used as a temporizing measure. As I have said, in warm AIHA, plasmapheresis is grade 3, is class 3 indication. However, in cold AIHA with massive hemolysis, plasmapheresis may be life-saving till the time rituximab and the other drugs work. However, transfusions must not be withheld, as I have said. Inline warmer must be used and patient must be kept in a warm environment. What is the mainstay of treatment in significantly symptomatic cold agglutinin disease? So in these patients, the treatment option is B-cell targeted therapy, which may be either rituximab monotherapy, 375 milligram per square meter weekly into 4 weeks, or 1 gram every 2 weeks into 2 doses. Or it can be bendamustine plus rituximab, which is administered as 28-day cycle. Bendamustine 90 milligram per square meter per day into 2 days, and rituximab in 375 milligram per square meter dose, and up to 3 to 4 cycles are administered, okay, to avoid toxicity. In the event of no response to this rituximab based therapies, bortezomib can be used, like short course of bortezomib, 4 doses, 1.3 milligram per square meter on days 1, 4, 8, 11. That means 4 doses, 1 course of bortezomib may be used. Even ibrutinib has also been tried as second line, although these are mainly retrospective study based evidence. Okay, so all these are B-cell targeted therapies. Other treatment options can be cyclophosphamide, particularly high dose cyclophosphamide for severe hemolysis, often in combination with interferon alpha. Okay, erythropoietin is an important adjunctive therapy for cold agglutinin disease, particularly in patients in whom the retic count is on the lower side. Okay, although these are retrospective studies, in small studies, erythropoietin can work and buy time for the B-cell targeted therapies to work. Unlike warm AIHA, glucocorticoids and splenectomy are usually not effective. However, exceptions are patients with IgG cold reacting antibodies, or patients with antibodies with a higher thermal amplitude, like those which work at around 30 degree or around that temperature, and in some patients with mixed warm and cold AIHA. Same with splenectomy. Splenectomy is not that effective in cold agglutinin disease because major site of hemolysis is the liver, not the spleen. However, in same conditions where steroids can work, splenectomy may also be effective, although in lower number of patients. Okay, like mixed warm and cold antibody AIHA, or antibodies with higher thermal amplitude, or IgG cold reacting antibodies. Okay, so this must be kept in mind. Steroids alone are not reliable for first line therapy in cold agglutinin disease, and rituximab therapy is often delayed, but it should never be delayed if there is suspicion of cold agglutinin disease. Now, just to briefly touch on some newer treatment options like anti-complement therapy, which do not reduce the antibody production, but they may be used to improve the anemia and fatigue and reduce transfusion requirements. I don't think these 2 agents are available in India. Sutimlimab has just recently been approved in 2022. It is a humanized monoclonal antibody targeting the C1s subunit of complement C1. Okay, it reduces extravascular hemolysis mediated by complement in cold agglutinin disease. Again, another molecule is pegcetacoplan, which is cyclic peptide inhibitor of C3 complement. Okay, it is administered subcutaneously, and sutimlimab is administered by IV intravenous route. Treatment of secondary cold agglutinin disease, same as the treatment of the underlying condition, plus rituximab may be tried. Okay, like if it's NHL, we have to go for chemotherapy. Usually it's B cell type, then rituximab combination with chemotherapy is helpful. Patients with polyclonal cold agglutinins like mycoplasma or post-viral, like infectious mononucleosis, typically they are self-limiting. However, they may require treatment if severe, and antibiotics may be used. If SLE or other autoimmune disorders are identified, then treatment should be directed at the underlying condition, as well as treatment may be required for significant hemolysis. Now, just coming to the brief discussion of PCH or paroxysmal cold hemoglobinuria. Classically, these are associated with Donath-Landsteiner antibodies, which are IgG antibodies which bind to P antigen of RBCs. Okay, historically it was associated with secondary syphilis. However, at present it is most common in children after a viral infection, and patients can present with intravascular hemolysis and related complications like hemoglobinuria, acute kidney injury. Okay, the peripheral blood smear in cold PCH may show RBC rosetting and or erythrophagocytosis. Okay. The DCT is usually positive to IgG and or C3d. Acute management of PCH, if the patient is having symptomatic hemolysis and hemoglobinuria, then patients may require short course of glucocorticoids. However, these may not be as effective as in warm AIHA. Exposure to cold must be avoided, and patient may need supportive treatment like hydration to prevent acute kidney injury. If there is recurrent or chronic hemolysis in PCH, which is rare, the patients may require other treatment like rituximab, azathioprine, or cyclophosphamide. So here I come to the end of my talk, and I have tried to make it interesting and practical tips for the students and postgraduates. If there is any question, I shall be happy to answer. I hand over to Dr. Debmallo.
Hello.
Yes, I can hear you.
So is there any question? It's a very nice presentation, elaborate presentation by Uttam sir. Hey Khushi, is there any chat box?
Yeah, there is a chat box. If anybody has any question, you can just write in the chat box.
Hello.
Yeah, if anybody has any question, any query, you can write in the chat box.
Hey Khushi, আমি chat box টা দেখতে পাচ্ছি না।
পার্টিসিপেন্টের পাশে দেখুন চ্যাট বক্স আছে।
I have opened my chat box.
না চ্যাটে বোধহয় নেই না।
Okay, I have how to diagnose DCT negative AIHA. As I have said, DAT negative AIHA may be due to different factors like non-IgG antibodies, or like antibodies with low affinity to these RBC antigens. So if the complete blood count, the reticulocyte count, and the clinical picture is in favor of AIHA, then even if it's that negative, we should go for therapy. Therapeutic trial is more important than diagnostic workup in majority of cases when the patient is sick. If the patient is relatively stable, then we should rule out other conditions, other differential diagnoses, like say in children, we have to rule out hereditary spherocytosis. Rarely sickle crisis can lead to similar picture. However, it is not difficult to diagnose even that negative AIJ. Okay. Sometimes monospecific Coombs reagent may be used if it is not clear with a polyspecific Coombs reagent. Dr. Manali. And you can increase the sensitivity of DCT test by using the column agglutination method, okay, which is really nowadays practiced in the blood banks. Gel cards. These are more reliable than the tube methods. Okay. Whether we should always treat them like warm AIJ. See, cold AIJ usually will either it will be asymptomatic, or if it is symptomatic, there will be RBC autoagglutination, and often there can be some monoclonal paraproteins like IgM IMGAS, or there will be evidence of indolent lymphoma, B lymphomas. So if it is that negative AIJ, then if you are convinced, patient stable, outpatient, you can try steroids. Later you can try rituximab, provided you have ruled out other differential diagnosis. If patient is hospitalized and has severe hemolysis, then you have to go all out. Then if there is suspicion, you should use rituximab early. You can try steroids. You may try plasmapheresis. It is my practical experience that plasmapheresis is often difficult because these patients are severely anemic. They often have hypoxemia and very low hemoglobins. So extracorporeal loss of blood during plasmapheresis is often associated with hemodynamic instability. Okay, whoever has treated a severe hemolytic, severe AIHA patient knows that it is often very difficult to stabilize the patient whatever you do. So you can even try IVIG in higher doses if patient can afford or it is feasible. Whatever you do, you have to start rituximab early. You can try high dose methylprednisolone. You can try IVIG, and transfusion. Transfusion must not be withheld. Okay. So the brief answer to your question, Dr. Manali, is it depends on the patient status, whether patient is stable, unstable, severe anemia, or just more mild anemia. Okay. Follow-up and monitoring for AIC. See, the most important monitoring is clinical monitoring, whether the patient is responding or not. The hemoglobin may take some time to increase. However, the CBC and reticulocyte count, along with the clinical picture, are most important means of monitoring. Okay, your target hemoglobin should be around 10 or above. Sometimes the patient may be stable even at a hemoglobin. If you increase the hemoglobin from 3 or 4 to around 7 or 8, then also the patient can be the symptoms can be relieved. So monitoring is by clinical evaluation, by CBC, and by reticulocyte count. LDH, although it is mentioned, I don't think it is more important than the clinical improvement or clinical status of the patient. Okay.
Okay. Any more questions from anyone? It's a very important question, and Sir's answer was very important for us, because he told that extensive diagnostic workup is not required than the treatment. So by doing the treatment, you can do the justice to the patient.
Even in iron deficiency anemia, it may not be a straightforward diagnosis. So we often go for a therapeutic trial.
Exactly.
So therapeutic trial is often more important side by side with the diagnostic evaluation. Okay, particularly if the patient is hospitalized or sick.
So students, you should not go by theory only. You should be more practical. Any more question? Okay, I think there are no more questions. Sir, I have a personal question.
Okay.
If the patients who are DCT negative and not responding to steroid or rituximab, how do you approach in those patients?
Do you mean an outpatient or? Inpatient.
Inpatients. Actually, I was telling you before the seminar, I personally had a similar patient whose all reports are negative. DCT negative, extensive Coombs test negative, all PNH screen negative,
Nah,
cold agglutinin negative.
what was the age of the patient?
44, pregnancy normal. Her baseline hemoglobin was around 8 to 9 throughout. This time she
MCV?
presented.
MCV?
MCV was normocytic normochrome. MCV was 110, and reticulocyte count was uncorrected was 16%, corrected 8%.
So see, if you rule out hereditary spherocytosis, which although it should not present at 44 years of age,
and no splenomegaly on CT scan.
Okay, so that makes it. So this is the typical presentation of warm that negative AIHA. If just tell me whether there was any increment of hemoglobin with rituximab or steroids.
No, patient has refused all type of treatment unless and until no diagnosis is achieved.
Okay, then how will you answer?
Exactly.
But
our plan was to do a dexamethasone or methylprednisolone trial for 3 days, pulse therapy. That what we do normally, but patient refused to go without any diagnosis. Google educated patient.
See if the and did you suspect cold agglutinin disease? Because often cold agglutinin disease patients are like that, relatively stable and slight worsening of symptoms in the colder, in the winters, like mild icterus, fatigue, drop in hemoglobin. I don't know, unless you try at least steroids, exactly. How will you know?
Okay. Exactly. So there's another question from one. She is asking about
how long to wait for any response in AIHA. I've already discussed, Dr. Siaram, that in AIHA, as per evidence, we should not wait beyond 3 weeks. Okay, for considering addition of a second drug like rituximab. If you are giving steroids in full dose, you can even try increasing the dose of prednisolone from 1 milligram per kg to 1.5 milligram per kg per day in adults. In children, you may straightway start with 2 milligram per kg in divided doses per day. However, if there is no response even after 3 weeks, so as per definition, it is steroid refractory. I'm quoting up to date here, okay? And that is an indication for if the hemoglobin is say around close to 10, you may still consider tapering steroids. If you are monitoring hemoglobin, tapering also I have clearly mentioned how to taper. It is often a confusion among everyone how to taper steroids. Each of one of us follow different regimens. However, very slow taper of steroids must be done. Okay. How common to find AIHA in transfusion dependent? Often there is a mix of allo antibodies and auto antibodies. What is your experience, Dr. Devmallo? I think you'll agree, na? In transfusion dependent, particularly THAL patients, THAL major patients, often they have a combination of allo antibodies are more important. Exactly. But often there can be some auto antibodies which can actually these auto antibodies can mask the detection of allo antibodies. So here it is more of a role for the transfusion medicine specialist rather than the clinician. Okay, but it is important because you have to give antigen negative blood to these patients if they have developed allo antibodies. Okay. So it is important for management of these thalassemia patients, and often we have seen that they have a mix of allo and auto antibodies. There we try steroids. Nah? Yes, sir. Sometimes steroid is tried. Okay, but again the long-term solution is antigen negative blood.
But fortunately these are rare cases. We don't face so much of patients having this type of combination. We unfortunately we face less number of patients with this type of combination, AIHA with thalassemia.
No. If you remember, we see patients. No, we used to see so many thalassemia patients. No, so because the number of patients was such huge, we used to come across some patients. No? which the blood bank people, transfusion medicine people used to diagnose for us.
Exactly, sir.
Then the treatment would be difficult because getting antigen negative blood is difficult. Often they have more than one alloantibodies like capital E or capital C along with kill or something. So practically it is a very difficult problem to manage such thalassemia patients.
Okay, sir. It is a nice revision for all of us regarding autoimmune hemolytic anemia's management. So, Khushi, is anyone's queries left?
So I think
No, probably no.
if there are no more questions, you can wind up the session.
Yes, sir. Thank you, Uttam, sir.
Thank you, Dr. Devmal, and thank you, ICHBT, for this opportunity.
Sir, these types of classes are good revisions for us who have away from academics nowadays.
Thank you, everyone.
Thank you, sir. Thank you all.
Okay.
Good night.
Good night.